Hello, dear friends and colleagues. My name is Dr. Fernando Verdugo. I'm a clinician, published author, and researcher. Today I want to talk about a landmark study that we published back in 2009 in Journal of Periodontology, the official journal of the American Academy of Periodontology. The study was titled Periodontal Biotype Influence on the Volume Maintenance of Onlay graft or autogenous block graft. And basically we wanted to evaluate the volume maintenance of those sites that receive block augmentation prior to implant placement. This is the first study describing the long-term influence of the periodontal biotype on the volume maintenance of block grafts performed in the anterior areas, maxilla and mandible. Bottom line, the adjacent teeth biotype does not influence the grafted site phenotype. In other words, autogenous block transplants can predictably reconstruct function and aesthetics and maintain stable bone volume at the augmented implant sites long-term. This is basically a quasi-experimental study evaluating the pre and post-op outcomes of a group of 40 patients that receive only block grafting, autogenous block grafting on the anterior maxilla or mandible prior to implant placement. So clinical parameters as well as CBCT data to evaluate bone volumes were done on a group of 40 patients that received autogenous block grafting in the anterior areas prior to implant placement. I want to emphasize that these were autogenous bone transplants. This is also one of the first studies using CBCT data to evaluate the volume maintenance of these grafted sites. Patients were followed for an average of 48 months, and on average, 98% of the Bucco-Lingual augmented width was maintained at that time. We measure the facial bone thickness at the implant sites and compare it to the buccal bone thickness at the adjacent teeth. All augmented sites had a statistically significantly greater buccal bone thickness at follow-up, that is 48 months, as compared to the adjacent teeth. The average buccal bone thickness at the augmented implant sites was about 2 millimeters, plus or minus 0.8. This study was published in Journal of Periodontology in 2009. We have published subsequently to that 2 more research articles in International Journal of Oral Maxillofacial Implants in 2011 and Clinical Implant Dentistry and Related Research in 2017. Confirming that autogenous block transplants maintain the volume long-term, providing a facial bone thickness superior to the facial bone thickness of the adjacent teeth. We have recently more long-term data over 10 years and above, 14 and 17 years, confirming again the excellent volume maintenance of autogenous block grafts in the anterior sextans, both maxilla and mandible. We'll be planning to publish this data soon, so more information will be coming up. Stay tuned, and please don't forget to subscribe and leave any message if you have any. Thank you. So these are some of the conclusions that we can draw from these 3 published data in 2009, 2011, and 2017. Autogenous block augmentation does not require 3 things. It does not require the use of membranes. It does not require the use of bone substitutes or biomaterials, and it does not require the use of a connective tissue graft for soft tissue augmentation. Additionally, there's no need for long healing periods of time since we are doing autogenous bone augmentation. So shortly after the block augmentation, in about 3 to 4 months, we are able to place the implant on the augmented site. As opposed to augmenting the site with a bone substitute, especially if those sites are large, the healing will require a minimum of 6 to 12 months depending on the size of the defect. Summarizing, these are 6 of the benefits that you will get from using autogenous block transplants or autogenous bone. We're using the patient's own bone. The healing times are much shorter. We are able to achieve stable clinical outcomes, soft and hard tissue, fast new bone formation and integration with the patient's native bone, superior bone quality, that is the formation of osteons composed of osteoblasts and osteocytes, are of much higher quality. Human histological data have shown the presence of osteoblasts and osteocytes for those augmented sites that receive autogenous block transplants. So we have a good, healthy formation of the osteon, which is the bone unit that we need for functional implant stability. The osteon is the functional unit of healthy autogenous bone and reduce overall cost, since we don't have to use biomaterials or membranes. If we were to take a biopsy of the augmented bone, we will see that the osteocytes are embedded in a lacunae, are healthy and vital. With healthy harvesting systems and blood supply. In this other study of autogenous block transplants performed in the premaxilla, published in Clinical Implant Dentistry and related research, we saw that the periosteal membrane seems sufficient as a barrier membrane to protect particulate and block autogenous grafts, provided that good primary closure is achieved. Furthermore, bone decortication may enhance clinical and histological outcomes. The biopsy specimens taken from the augmented sites in the premaxilla showed viable bone rich in osteoblast-like cells with little or no inflammatory cells present. The biopsies were taken at the time of implant placement, that is 3 to 4 months after augmentation. We have also noticed that the implant sites that receive autogenous block augmentation were less prone to mucosal recession, less prone than the adjacent teeth, that is. So in this follow-up cross-sectional study, we showed that teeth adjacent to implant sites that had been augmented with blocks were up to 7 times more likely to present a recession than the implants. So the teeth were more prone to recession, possibly as a result of a thin biotype. This study was done in a group of patients that received block grafting in the premaxilla. These were a group of 40 patients that were followed for 52 months. And it was determined that a buccal bone thickness of about 2.2 millimeters is optimal for peri-implant tissue stability in the premaxilla. Optimal in terms of providing proper aesthetics, lack of implant transparency, and prevent from peri-implant mucosal soft tissue recession.